This episode of The Benefit Whisper is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget. Welcome everybody to another Benefit Whisper episode, a very exciting one. I have with me, I'm privileged to have with me the one and only Matthew Zachary, who has written a book, and it's a very, very important book because it's about what healthcare should be about, which is the patient. Okay. And it's, in my opinion, probably why most doctors are in healthcare, but why the industry treats the patient as a profit center. Matthew, welcome to the show. Glad to have you here today.
It's an absolute pleasure, Ralph. Thank you for having me on the show.
Yeah, great. So tell me a little bit about your book. Tell our listeners what's the book about.
Well, the insight is that it's like a dark, sardonic comedy about why American healthcare can never have nice things since 1910. That's kind of where it started from.
Yeah.
I just bring a lot of sort of accidental pedigree. I happen to be a survivor. I happen to have gone through 30 years of crazy shit. I've worn, every hat except I haven't worked in pharma. I'm not a lawyer. I've never passed a bill. Everything else, I've kind of done a version of that.
Oh, wow.
So, and I've always been independent.
Right.
So I just have a very enviable Rolodex of people I'm very proud of. I have trust with millions of people. I can have an opinion. Many people can't. I could say what's in people's heads that they can't. I'm not golden handcuffed or shackled anywhere. And I'm just brutally honest about where I feel there can be improvements, where there are inefficiencies, and from the perspective mostly of a patient who's been chewed up by the system, but also an entrepreneur, an investor, a startup guy, nonprofit guy, pharma guy, marketing guy, Omnicom guy. And I at some point during that pandemic, I realized that someone's like, you should write a book, but not a memoir. No one cares about that.
Right.
So well, if I'm going to write an angry book, what the hell could I write about?
Right.
But the overarching thing, and this really wasn't a thing that was necessary to be angry about 10 years ago.
Yeah.
Is just the ever encroaching malfeasance and abuse that the health insurance industry has wrought upon America. It has one of the highest bipartisan approval ratings of hatred.
Yeah.
It's like they hate him more than Congress, right? It's really, really bad.
Right.
Very few Americans are, some of them, you're happy with what you have if you don't need it. And that's not normally how it works.
No.
So I wanted to write a book about progress first and foremost. The perspective that 30 years ago, we just kind of died. There were four chemos. There was no laparoscopy and whatever it was. And we have different, better and different, worse problems today.
Yeah.
But the second part was basically that health insurance is now the gatekeeper of your death. And
wow, that's an
jargon
interesting way to put it,
of
but you're right.
Yeah. Yes. This is the consumer patient perspective. And forget our jargon about social determinants of health and no one gives a shit. Someone in Oklahoma with cancer doesn't need to know that jargon. They just don't want to die, and they don't want their health insurance to be their doctor and tell them no. That's what this book is about. The evolution of how that happened and what it does to chew up the people inside it and what that means to American culture.
Right. Yeah, absolutely. And I recently did sort of a 6-episode mini-series within the Benefit Whisper about the history of health insurance in America over the last 100 years, starting in 1929. When the Baylor Teachers Plan formed the first ever prepaid healthcare plan, which later became Blue Cross. And back then, it had one goal, and that was to solve an issue called liquidity. Nobody was working. People were being bankrupted by hospital bills because they didn't have jobs. Hospitals were swimming in debt. So that was supposed to solve liquidity on both sides, the patient and the provider. Okay. So that's where it all started. And then many, many, many things happened after that all of which removed the patient and the provider further and further apart, removed that relationship, turned it into a V, where at the bottom of the V is the payer, and then each side has sort of their own interests, which diverge more and more. And all the, and I spoke to Mark Cuban about this, all the middlemen that have been added, rent seekers, into the equation. So, it's amazing how much you and I are on the same page. We could be brothers.
Yeah. Like I said, it's like a Lenny and Squiggy from Shirley.
Yeah.
It's the same. We just say the same thing from different sides, or like Louie and Jim from Taxi. I'm dating myself, but we tick roughly the same census box, so we're going to get our references here. It's funny if you go back, even 25 years earlier than the Great Depression or the start of the Great Depression.
Right.
I write in my book about how Teddy Roosevelt was the first president to try to get universal health care. And it was the start of why we can't have nice things, because the railroad tycoons and the robber barons wanted their employees to be theirs. So they bribed the American Medical Association. They ripped off the American Cancer Society, which was just getting started back then. And the AFL, before the CIO, just took charge of employment. So that's kind of where it started, from just robber baron greed. And here we are 130 years later. At this point, 120 years later, and it's still robber baron greed.
Yeah. Yes. Yeah. It sure is. No question about that. And the thing is, Matthew, I think everybody agrees that there's nothing wrong with having a business and making a profit, but gouging and treating people like profit centers, really. Do you remember the movie Network back in, when was it?
Mad as Hell, not going to take it anymore.
Yeah,
for sure.
Yeah. That's when I had the episode with, Mark Cuban and Kevin Schulman from Stanford, we all said, I'm mad as hell, I'm not going to take it anymore. But really, that's where we're at. I just don't know what we would pick up, to throw out the window. But everybody is mad as hell about health insurance. And I posed a question a while ago on LinkedIn. I said, when we say healthcare, what does that mean? You ask 10 different people and you'll get 10 different answers. Healthcare means I can get my annual physical. Healthcare means somebody will pay for my medical care. Healthcare means going to the doctor and getting a physical. It's different to everybody. But at the end of the day, the way I see it, there are two different things. Medical care on the one side, which is doctors and hospitals providing medical care, immunizations, examinations, surgeries, chemos, radiations, et cetera, et cetera. And then on the other side, there's healthcare finance, which has very little to do with health or care. It's just really an opaque system and when you think of it, when you think of healthcare, the way we talk about healthcare today in this country, we think it doesn't make sense. Why is it working like this? Well, it doesn't make sense if you think that it's supposed to provide health or care. But if you think of what it has become, what it has morphed into, it makes perfect sense. It's basically distressed finances, with hospitals being the largest collection agencies in the country.
Yeah, I've heard it referred to as profitable expenses.
Yes. Yeah. So I did a little take on the Mad as Hell thing, and which I'll send you after, but it's, when he's Howard Beale says, I'm a human being, God damn it, my life has value. And that's it. And, we have to say to the insurance companies, I'm not a profit center. My health has value. And that's what it boils down to, is we are being used as pawns, and the denial system. One of the things that I talk about a lot, because everybody thinks, AI is going to be our savior. AI is going to speed things up. The problem is the system is so broken. All it's going to do is accelerate the mistakes. When I had Don Berwick on Friday, we talked about that, and he's in complete agreement with us as well. He's on the same side of the formula. And the thing is, what AI, that black box, we talked about that black box, that opaque black box with the denial rules. And he said something very meaningful. Fiduciary duty. The question I posed is an employer honoring or fulfilling their fiduciary duty if they cannot explain to one of their employees that participates in the health plan what the rules are for denial? And no, the answer is no. They're really not. So this black box, this opaque black box, AI is just going to accelerate something that's screwed up, getting screwed faster. That's what I call it now.
No, you're spot on. But on the receiving side of this,
Yep.
No employer wants to have unhappy employees.
No, exactly.
Period. But also, no employee wants to hope that their employer has decent healthcare insurance policies.
Right.
And that alone is also the crapshoot no one asks for. I just want a job to pay my rent and not be miserable and do whatever I need to do to live this life. The last thing I'm going to read is the iTunes terms of service to make sure that it includes asthma inhalers and shit for my knee that doesn't work and podiatry, God knows what. Right. And you can't expect to explain that to the average American. No one understands this. No one reads this. And I think that's been one of my grievances. I mean, many is that be your own advocate is bullshit. Be your own advocate is absolute and total automatic systemic failure personified. That you should even have to be your own advocate is the abject failure status. And I like to poke the bear a little bit in case anyone hasn't noticed that. But there's two things here. I've heard doctors. I'm part of a burnout documentary with Mark called "Suck It Up, Buttercup." It's basically big middle finger to private equity and rural health and United Healthcare on how they basically destroyed Hippocrates. Yeah. And one of the doctors there doesn't say American healthcare isn't broken. He says it's fixed, just not for the patient. And I say it's not broken. It was built this way, which is the same thing. Exactly. And I just say that to stop people from saying broken. Yeah. Because anyway, where my head goes on what you just articulated goes back to something I write about in the book, something I've talked about for a while. I mean, the allegory is I've been on the air since 2007 with dial-up and those modem sounds. Yeah. We've been doing patient advocacy and healthcare reform and whatever the hell innovation means for 20 years, and it's the same shit, different day. You march a bald kid out to Capitol Hill, take some photos with a zygote staffer that has no idea what the fuck's going on, that represents an octogenarian who should have been kicked out of Congress 40 years ago, and nothing ever happens. Right. So I took a lot of cues of the 30 years I happen to still be above the grass. I remember Larry Kramer, an actor. I remember the March on Washington in 1998 with the National Coalition for Cancer Survivorship. I was incubated at Livestrong when we were just uniting around this all sucks for all of us before healthcare made it worse. And of course, I launched a global movement of millions of Americans and international patients with stupid cancer. So organizing is something that I haven't seen happen in America since 2012 with ACA. That was it. Right. So my theorem now and my process now and where I want to leave readers in the book, it's one thing to be pissed and say, go raise money for research. It won't matter if Aetna says no. And I'm picking on Aetna and Cigna and United Healthcare and the usual suspects. Right. What needs to happen now is there needs to be a citizen organizing against healthcare's harm. Going back to your point about how Hippocrates should include financial harm, mental harm, physical harm, and again, separating hospital errors from all that other natural way to think about harm. Yeah. That's where I feel what's been missing in this country is a unified, not a PAC and not a lobby group, a unified voter bloc of 50 million Americans, which is insane potential because everyone doesn't want, not to use double negatives, no one wants to go broke, to have, GoFundMe be your cure, to have your insurance tell your doctor to go, fuck himself, and to be denied for no reason on purpose just to waste money and time to get approved later on. No one wants that. No, you're absolutely right. Not only does nobody want that, nobody asked for it, nobody deserves it. And no one voted for it.
Exactly. And when you think about the four main parties in the healthcare transaction, the patient, the employer, the provider, and the payer, and then the hundreds of middlemen that are all in between the stuff that are simply the pawns. At the end of the day, given the system that we have, which is primarily employer-based, other than Medicare, Medicaid, it has to be affordable for both sides. Now, the part that goes missing, and we've talked about this a lot, the administrative waste is $1.7 trillion a year. I shouldn't say that's the administrative waste. That's the administrative portion of the total bill. So
but
about
there's a lot of waste in there.
Oh, yeah. There's a lot of tons of waste. But, to administer healthcare payment, it goes through 43 steps. The life of a bill is 43 steps from the hospital to when it gets paid, which is ridiculous. Every other industry, Matthew, you go to a restaurant, you eat the meal, you see the prices on the menu before you pick, and then you pay before you leave. You book a flight. You pay when you book it. You book a theater ticket. Like everything is the payment and the service is linked directly or shortly before or after, except in healthcare. And if you think of the days sales outstanding, the amount of time that it takes and the erosion, it is similar in healthcare that, it's distressed finance. It's like construction, litigation, bankruptcies, the delay of service and the erosion. So what the hospitals end up doing, this is, the theory that I'm talking about in the paper that I'm writing. My theory is that the hospitals know that they're not going to get what they're supposed to get. And because of that, they build in this uncertainty premium. Okay. So part of the hospital bill, part of what they negotiate includes the fact that there are going to be denials. There are going to be uncollectible balances. There are going to be patient write-offs, et cetera, et cetera. So that's one of the things that boosts it up. And it doesn't have to be that way. It really doesn't.
Well, the other side of that also is the malfeasance of the payers themselves. In their annual budgets is $1 billion of legal fees, right?
Mm-hmm.
Like they just plan to be sued. And, to Mark's point, or maybe a little skewed to Mark's point, they're unshameable. And Mark is just trying to shame them, and it's never going to work. I appreciate what he's done for Cost Plus. I want to be Cost Plus spokesperson. I'm on 7 meds for the rest of my life, right? 7 meds that, I mean, never look under the hood. This is fine. Exterior, right, Doc? So of those 7 meds, 5 are generic and 2 of them are I can't go off brand. But I moved those 5 to Cost Plus, and I'm saved. My household is saving $300 for 90-day supply. Every 3 months, we just don't spend $300. I'm spending cash for, and I fired my copay because of what Mark brought to market. It's phenomenal. Everyone understands this. It's bullshit. There's middlemen. Even, lay people get that part. Why is it cheaper if I go to Mexico or Europe? We get that part. But what's missing is that you can't shame them. How do you hit them in the wallet? Is the other part that no one's really exploring. What is the economic benefit of eliminating this middleman? And I talk in my book, and this is a stat news like golden data amongst all of your known, waste and fraud. There's $30 billion a year wasted every year because of intentional denials that wind up costing more money to fix. So there's $10 billion lost in denials that should not have been denied. Speaking of AI ruining everything. And then it takes $20 billion to fix those $10 billion. So $30 billion in waste divided by the states, divided by ecology, divided by states. States are losing. Medicare's losing. Employers are losing. Hospitals are losing. Billions a year. So this is my second theory. I'd love your thoughts on this. It is in the book. And I hate making up terms to make them sound like they're a layperson.
Sure.
But healthcare and harm reduction really kind of go hand in hand with infrastructure. Safe roads, safe tunnels, safe schools, safe houses, safe this. What is safe, protected healthcare for the average constituent? And for me, the harm reduction are consumer protection. I'm going the Liz Warren route. Yep. Can there be a consumer protection law that exists that bans delay, deny more than 14 days, that forces arbitration, that the states already know how to get you out of trouble, that basically do oncology debt write-offs. So if you can abet, what's the word, or abate, or get build an upstream where the $10 billion just never happens in the first place.
Right. Yeah.
Think about the Ralph Nader, seatbelts are better, safer, cheaper. Maybe healthcare can be better, safer, cheaper by building an upstream. And that reduces burnout, that reduces hours of paperwork. And then there's just so much. I hate the fact that we even have to do this in this country. But if that's a path to getting rid of a $30 billion spend that doesn't need to happen, that's on purpose, then you hit them on the wallet.
Right. No, exactly. Are you familiar with the Himmelstein-Wolfhandler graph, growth of administrators versus physicians? Do you know the graph?
I'm not, but I'm probably going to be very angered by your telling me about it.
It talks about, and I forget the exact period. I think it's like from 1970 till today. It might be tighter. It probably is tighter than that. Of course, the HMO Act passed in 73, so it is tighter than that. But anyway, during this defined period of time, both growth of doctors grew by 250%, while the growth of administrators was 4,800%.
I saw that. It's like $7 trillion over the last 20 years, like showed up out of nowhere.
No, exactly. And, then on top of it, the doctors themselves have to justify to the payers all that they're doing,
Right.
And that leads to burnout too. When a doctor becomes, accountable to the payer, they should be accountable to the patient that they're treating. Not to the TPA that just administers the healthcare payment. I mean, that's, talking about bullshit. That's total bullshit.
Yeah.
But on top of it, and I kind of lost my train of thought because I got off on this tangent. But, the big thing is about all of these payments and all of these steps that I talked about that a hospital bill has to go through, and the number of administrators, it's really just a system to make money for the payers. As Mark said, and Don said this too, billions, tens of billions, hundreds of billions, maybe even trillions that's sitting in the system. Even a 1 or 2 day delay will make a ton of money on the float. Okay. So, that's just one of the profit models that the payers are using.
Well, Mark is very good about the economics of inefficiency. That is not my lane. That's his Venn diagram.
Right.
I'm not a billionaire that used to own a baseball team. He's the basketball. I didn't even know, some sports team, whatever it was.
Right.
And but then where are the financial incentives to fix the inefficiencies? Who makes the most? I have an op-ed coming out on BBC pretty soon called "Who Profits When Patients Win."
Right.
And if we're thinking of protections, when employers win, when there's no downstream of waste.
Right.
But who fully pro-capitalist? This is not like my Wall Street. I can still say profits over patients without saying you can make all the money you want. In fact, my closing remark in the documentary with Mark was make all the fucking money you want. Try to kill us a little less. Maybe not all the money you want, but you can harm us less and still make your profits.
Yeah, absolutely. My financial model, what I've done is, and I've done a ton of research over the years, and what I've put together has to do, it wraps the RAND study and all this prior research, and it puts them all together, and it talks about the erosion. So the average hospital gets paid roughly 67% of what they're supposed to get paid because of the erosion, right?
Yeah.
So, I'm working on a break-even scenario where, number one, if all of these steps weren't needed, this prior auth, et cetera, how much could they get away with? And I just remembered what I was going to talk about because you asked me about the prior auth. We were talking on Friday about Medicare Advantage.
Which again is Medicare Disadvantage.
Medicare Disadvantage, exactly, yeah. So in Medicare Disadvantage, and I'm trying to remember off of the top of my head the statistic, 7.1 million claims were that were denied were appealed. 88% of denials were not appealed, but those that were appealed, 80% of were overturned.
Yes.
In other words, they were appealed for the wrong reasons. They shouldn't have been appealed. So these 80% of 7 million, people or denials wasted all this money appealing something that should have never been appealed in the first place.
That's the $30 billion. That's exactly it. And it's worse in oncology. Let me give you our stats. In the vertical of oncology alone, it's probably 80% of the denials that are appealed are approved in oncology.
Right. Yep.
But guess what percentage of denials are not appealed at all in oncology?
On Medicare Advantage, it was 88% overall. So I'm guessing it's somewhere around there. I'm going to guess 80%.
All right. 02% of denials in oncology are appealed. Percent.
Wow.
But of
so
those
99.8.
Wow. Yes. That's oncology. Of those 0.02, 80% of those are approved.
Wow. And that's $30 billion.
The $30 billion is across the board nationwide per annum.
Gotcha.
And that's a 2024 stat from Stat. I'm sure it's way worse now with the just the lack of regulations and the complete depletion of any responsibility whatsoever. Even after they murdered Brian Thompson and they tried to kill the Aetna guy, like we're at a point now where we're going like Che Guevara here. And if that isn't a sign that this country is in pain, I don't know what it's going to take.
Yeah, I mean, every 58
Wait, can you hold for 1 second?
Yes.
My doorbell just rang. 1 second.
Sure.
I'm glad this is pre-taped. Give me a sec. Hang on.
Yep.
When you're the only guy here, sorry, the disadvantage of being a solo act.
Yeah.
All right.
No worries.
All right. Let me get this back where I was. We just talked about how that 30 billion the redonkulous micro percentage in oncology specifically, but that 30 billion is across the board, and it really is. That's from 2024. So I'm sure it's much worse now with the complete depletion of morals in the health insurance industry.
You know, and with AI, Matthew, I think that AI could do some good things in healthcare, but right now, the way people are planning to use it, I don't think it's good, because it just means you're getting screwed quicker, really. You know, that it speeds up the fuck ups, you know. That's all it does. And you're going to have on the provider side more AI-based denials, on the provider side more AI-based appeals, and they're going to be, you know, AI against AI. And like if you and I decided to have an argument by email and we're both using AI, each of our AI models would adapt to that argument, and each of them would say that we're right. So that's what you're going to have, is this crazy thing. It's kind of like, this might be before your time, but it kind of reminds me of driving a Ford Pinto with a full tank of gas with a jet engine strapped on the roof.
Right.
You know, you're just one pothole away from, you know, the thing blowing up.
Yep. A Gremlin, a Pacer, and what was the third one? Gremlin, the Pacer, and the Pinto. All three of them.
And the Pinto, yeah. And Firestone 500 tires, those two. Yeah, but I mean, that's where we're headed. And it's scary. It really is scary. You know, and my background is as an air traffic controller. And what I am trained to do is, because air traffic control has a zero tolerance for error, zero tolerance. Okay? Make a mistake, people die. Boom. And not just one person, 1,000 people can die if you make one mistake. So sometimes I have to jump into chaos, look from the top down, figure out what the hell's going on, and straighten it out and get people flowing, you know, in the right direction again. But there's so many pieces, so many diverging and, you know, distances, airspeeds, climb speeds, visibility. There's so many dimensions that figure into it. And in healthcare, it's the same thing. So, you know, if you look from the top down, as I often do, you can see a lot of the pieces that are by design, you know, divergent needs, not even needs, divergent, what's the word I'm looking for? Interests, divergent interests. But
you know, you would agree though that air traffic control would totally benefit from two AIs angering with each other, because they're both out for patient safety. Because if there's no patient safety, there's harm, there's loss, there's insurance. You know, there's accountability in the consumer world. And
Yes.
I cut my teeth at Omnicom for 10 years in the 90s. I learned a lot about how to manipulate people and work in consumers and sell Doritos and all that crap. When there's a demand market, they know that they could tank like the Pinto by making something terrible, right?
Yeah. Yes.
To Ralph Nader's point and the Corvair and shaming GM, it worked. No one wanted to buy cars that would kill you. They wanted to buy the cars with the seatbelts. They were looking for safety because they built a demand market. Healthcare, outside of break fix and annual visits, normal shit, that's okay. But there's no demand market for oncology care. There's no demand market for GLP-1. Now there is, but there's no demand market for your kid having asthma and eczema. And that's where the malfeasance is, because you're not expected to know what to do. They completely build a business model around that ignorance.
Right. Yes, they do. Well, they build a business model to take advantage of the ignorance. The opacity is the revenue generator. It's the business model. It becomes that business, the confusion, the opacity, that's what drives the profit. And they're using it. It's engineered to do that.
Yeah, built this way. We have the same thing.
Yeah,
exactly.
Yeah.
But then the what if, the Dale Carnegie just suppose moments that I talk about whenever I go anywhere. What happens when that 0.02% becomes 5%? What happens when more than 50% of cancer patients are given the tools to avoid the downstream fuckery? What happens when 50 million Americans organize a nonviolent bipartisan voter bloc demanding in our states harm reduction from financial toxicity? What happens when all that wasted money goes back to the people it belongs to, the systems it belongs to? Medicare Advantage is robbing the government left and right as like the worst offender of forget all the other crap they're wasting money on. But you look at how much abuse there is at the behest, of corporate interests and shareholders and at the expense of the American voter.
Yeah. Exactly. And all of those shareholders, whether it's a teacher's pension plan or an individual investor, they're cheering when their money grows. Okay. If they knew that, that meant that somebody was denied necessary treatment, how would they think? And how can we connect those two more tightly so that they are, because they are connected, but how can we make people see that, Matthew?
Yeah,
that's my question.
Again,
that's only
money and power. It's to Mark's point again. It's the transfer of money and power. Who makes the most money when the incentives work in favor of the voter? Period. It's that straightforward. And I'm not saying this as any kind of pundit. It's just the natural law of sort of socioeconomic anthropology. They use lots of syllables right there. People are incentivized to vote in single interest strategies. What unites people aren't gun rights and abortion and all this crap and redistricting. That's complicated stuff. You want to be able to walk into some place you didn't want to be in before and just not get screwed. Period. And how can you be protected from that? By being part of a bloc that demands it. That's what I'm suppositioning in my book.
Yeah. Well, and that's great. I had the privilege of sort of doing a pre-read, which I really appreciate, but I want an autographed copy. I'm going to order one. When can I order it?
You can order it today. It'll be delivered to Amazon Prime. I've been in pre-sales mode since December. And the book's done so well. We're in our second printing.
Wow.
Pre-orders are through the roof, and I was just told by my publisher, I wouldn't know this, first-time author, no one gets to their second publishing before their pub date.
Right. Yeah, that is amazing. And that just shows you how needed it is. And we both know this. And I'm glad that you're out there talking about it. Like when I was reading it, I was thinking, wait, did I write this? Somebody took my thoughts and put them on pages, because, this is a lot of things that, not as eloquently as you, but these are a lot of the things that I speak about. My wife is a physician, and so we are on the same page in terms of the patient comes first, not the dollar. Okay.
Right.
And not the profit of the payer. It's really that simple. In my mind, I tend to think that this whole thing is really simple. It's not easy, but it's really simple to fix. We just need that. And if we get 50 million people, I think that will drive it. And the employers need to get involved too. To Mark's point, I've worked on I've got a tool called the denominator audit, where CEOs often think, okay, now we know that Starbucks spends more on healthcare than they do on coffee beans. Okay. And that is number one, that should be a startling statistic to start with. But when a large company thinks that, maybe there's, depending on the industry and 1,000 variables, they could be spending anywhere between 1 and 30% of their total top line sales on healthcare. And if they're in the low single digits, 1, 2, 3, 4, 5%, they think, okay, if I save 30% on my healthcare spend, that's only 1/3%, for example. It's not worth thinking about. However, what I've done is I've said, that's the wrong question to ask. Here's the right question that an employer needs to be asking. An employer needs to say, what percentage is this of my after-tax profit? And then to take it one step further, what effect would saving this money have on my company's enterprise value? Because once companies, whether they're public or private, start thinking like that, then they're going to pay more attention. Once they start paying more attention, and that, again, you're solving the part for the patient. I'm concerned about that too. I'm solving for that. I'm working on something that's going to have a very, very low, if not zero, responsibility by the patient. Certainly, the responsibility for collecting the money should be the plan sponsor, in my opinion, not the provider. Okay.
Right.
So if I solve for the other side, which is let's get the companies, the CEOs, the CFOs more involved. Let's get them pushing for change because they are hosting the payment mechanism by creating an employee welfare arrangement. Then we're going to get the push from two sides, the employer and the employer patient. And I think that would give even more momentum.
Yeah. And my question to that part of the resort, so to speak, is how can a multi-million voter block help you do that? And how do you help us do this?
Yes. Yep. Absolutely. And that is, wow. I mean, that's something that you and I need to put our heads together on and figure out how to do. I know it can. There's no question because, it's like, who is the customer in the transaction? Okay. Is it the patient? Is it the employer? The insurance companies like to think it's them.
It's the prescriber. It's, we're going to let you, doc, give this patient this medicine. Patients are the end recipient of we are the receipt, basically, after the cash register goes ding, ding.
Yep.
And we're stuck with whatever the receipt's going to say on it. It's a store you don't expect to go shopping in. Like you said, there's no Groupon for chemo.
Yeah. No, exactly. And, the other thing, Matthew, is there's no price in healthcare. Okay. When you go to a restaurant, you look at the menu, you see the price. I mean, other than maybe adding a tip, maybe adding taxes, service fees, whatever, the price is the price. But in healthcare, there really is no price. Imagine if you ordered something from Amazon, you found out 3 months after you ordered it, how much it cost, and only after going through 5 intermediaries and getting all kinds of confusing information. That's what it's like. And that's crazy. I mean, that's screwed up. That's messed up.
Like I said, we were only going to agree on things. I do want to point out one, I guess I ended my book on a happy note. I wanted to prove that it can work when it knows it can, and it chooses not to with malfeasant intention. I went through a brain cancer scare. Like, it wasn't, I'm fine.
I'm sorry. Yeah.
But I developed like double vision out of nowhere and needed glasses, and my pupil dilated and all this crazy stuff. And I'm on my wife's employer plan, which is actually surprisingly decent. Again, you shouldn't have to happen to work for someone who happens to have good. There's so many ifs in that algorithm, in that permutation. But she happens to work in an employer that happens to have a decent policy, and they take care of their employees. And I spent a year basically trying to debug what was wrong with me to figure things out. Turns out I had like a mild third nerve palsy, and they fixed it. But I spent a year, no surprise billing, no wait times. Everything was pre-authorized.
Mhm.
No extra costs. No oops. Nothing across
Mhm.
like 8 doctors and 2 health systems and
Right.
dozens of tests and scans and surgery. We were out of pocket maybe $800 the whole time. So
Wow.
it is possible. That's
Mhm.
my whole point. It
Yeah.
is possible that it can work, and it does work. And
Right.
I had to end the book on that very point.
Mhm.
It's not all terrible when people still know they can make a profit.
Yes.
But on your side, there's still tons of stress when you have to spend your time telling the insurance company's doctor that you know better than them.
Mhm. Yeah.
And that goes back to where we started from, which is health insurance is now the new barrier to death.
Yeah. Yeah. No, it is. It is. Um, it is sad, Matthew, that we have to rely on the employer system, but that's what we have for now.
Yeah.
Okay. So let's fix what we have. And I agree, it can be done. It can be done profitably. Okay.
Yes.
It can be done, and AI can help, but the way that people are applying it now, I think it'll do the opposite. I think it'll just speed up the spending and the chaos. So
yes, it will. And they'll be arguing with each other.
exactly. So, wow, this has been a great conversation. We're coming up to the end. If people want to buy your book, become involved, be part of the movement, how do they find you? How do they get involved?
I have the fortune, The Patience, Understanding, Navigating, and Surviving America's Healthcare Nightmare on sale now wherever books are sold. But I have the privilege of being on the internet so damn long that I'm the only Matthew Zachary. So it's not that complicated to find me if you just type my name anywhere into AI, into anything. You'll find me. You'll find the book. It's the only We the Patients book on Amazon that I'm aware of. And I'm here to help. I'm alive somehow. And if you can get Mark to read it, I'll buy you dinner.
Wow. Okay. That sounds good. That's let's talk about that for 1 second. Buy you dinner. Okay. Because I'm getting into Milton Friedman here, kind of.
Okay.
Milton Friedman meets Marty Feldman. Okay. Now,
now I'm in Young Frankenstein land. Great. Fantastic.
What was it that Mel Brooks said, in the part, History of the World, part 1 about the rich people? What about the poor?
Oh,
when he was in the Senate, right? Yeah. Yeah.
Fuck the poor.
Yeah. So, it's interesting because if I say, hey, listen, I appreciate you being on my show. I want to buy you lunch. I can't make it up there. And you say, hey, great. And you're thinking Ruth Chris Steakhouse. You're thinking Steak and Lobster. And I'm thinking Wendy's, right? Okay. But when you get 100 people all chipping in, then all of a sudden, nobody starts thinking of how they can game the system or how they can pay less. Okay.
Right.
And that's part of the problem, is that we don't see it. Okay. So one of
but at
many
least we know
things,
the prices.
Yeah. Exactly. We need prices. Wow. I'm just going on here, but Mulroney, Senator Mike Mulroney. Have you ever heard that name?
I have not.
He was a senator in Oklahoma, state senator, I believe, in 1955. And he passed a bill called to this day, the stickers are called Mulroney stickers by people in the automotive industry, because at that time you can go from one dealership to another and have completely different prices in the same town.
Yes. Mm-hmm.
Okay. Just like hospitals do now. So what a lot of people call the MSRP stickers means if you buy a Toyota Corolla at this dealer versus that dealer, the same MSRP sticker is going to be on there. It's going to say how much was the car, how much was the power steering, how much were the tire, etc. Okay. So the Mulroney sticker, and I've been saying this for a long time, this is another thing we need in healthcare, is a Mulroney sticker where it lists all that.
That is a consumer protection.
Yes, it is.
Going back to the other thing we talked about, consumer protection. How do you ensure the safety, in my case, of the oncology patient who isn't told no, gets worse and costs more and dies?
Right. Yes.
Safety.
Absolutely. Well, great having you on. We're going to have to do this again, Matthew, for sure. This has been
I
a
love
great
it, yes.
episode, and I appreciate all you're doing for patients.
Likewise. Thank you so much for having me. It's a privilege to follow Mark on your show. And if you can get him to write me back one of these days, I'd appreciate it.
Sure. I'll see what I can do. He's amazing. He's doing a lot of good things.
He's a lot of good. He needs a patient photo block. We can make that happen.
Yep. Sounds good. Thanks, Matthew.
I appreciate it. Take care of yourself.